coming and thank you for attending. It's a very, very controversial topic, and the data is still developing for this kind of approach. But there's been so much said on this in the last few meetings, so I thought we would take it up as an area that we could all get our inputs into. And the reason probably that we're doing this is this piece of NCCN guideline. And if you look on your right where I've crossed it, definitely they have recommended that it can, preoperative systemic therapy can be considered for T1C N0 tumors who are HER2 positive in TNBC. And of course, the practical point of view is wherever you want to delay for some reason the definitive surgery. So, going back to the first slide, we are going to talk about which of these patients, if at all, our surgeons would consider referring for NECT. We don't know the cutoffs. It's all dependent on which institution you practice in. And I think a lot of us see less of such tumors in our country. And why are we so bothered about T1C? What is the real rate of recurrence? And why would we give neoadjuvant apart from definitive surgery being delayed? There's less clarity on that. And if, as a medical oncologist, we are going to be referred such patients in the future, then we always worry about overtreatment and what kind of neoadjuvant treatment. So this is going to be more of a panel, and I think not many of us have too many cases and experience with this. We will get Dr. Kothari's inputs because he's perhaps sees so many screen detected tumors in the UK, and a lot of us in private practice is changing, so we'll get a kind of consensus from our participants as well. So going to our first, whoever, Nita, you could take this. How often do you see these tumors in your practice setting? You moved now
So,
from Tata Hospital to
right.
private.
So I actually just audited my work very recently, and my median tumor size has dropped to, I'm going to say, 2.2 centimeters, which
Mm,
means that less than 50% of my patients are under 2 centimeters. So I am seeing them more often because we do have a screening program in place, which is called Pro Health at Apollo. We
okay,
do
okay.
have women who come in for health checkups. So we are picking them up. And not that my practice is very big, but we are seeing it, and it's not something that's completely uncommon. Fortunately, most of these women are ERPR positive, HER2 negative. I'm not seeing those many TNBCs and HER2 positives that are small. But
Yeah.
I do have anecdotal cases, and currently, my patients are more or less getting operated upfront unless
Pranjali,
they are
what
node
about you?
positive.
What
Um,
about you, Pranjali?
yeah, so interestingly, I also see that we are diagnosing smaller tumors in the young age group women because they are more, there is a higher acceptance of screening. So, like the girls who are now turning 40 in the last few years have heard it somewhere that we need to start screening and do mammography compared
Mm,
to women who have already reached the
mm,
60s and haven't been doing it for 20 years. They're still not.
mm.
So I think, surprisingly, I'm seeing smaller tumors in the 40-year-olds who have just started screening and now they're, so that's just a point. But yeah, infrequent, but yeah, we're seeing smaller, TNBC is not very common, but yeah, we're finding screening detected cancer.
HER2 positives, probably ER positives, you're finding them smaller. Dr. Tahir, Dr. Tahir is a pathologist with Ruby Hall Clinic. Uh, as a pathologist and with a special interest in breast cancer, tell me how often do you see T1cN0? How often do you report that stage in your practice?
Uh, Hello, everyone. Can you hear me?
Yes.
Yeah. So the T1C is probably is getting, we are seeing more frequently compared to the higher stage cancers. Uh, it is getting more and more prevalent now because of this screening, as Ma'am has mentioned. and we report which is recommended by the College of American Pathologists. The grade, stage, the LVI is there or not, the lymph node status, whether lymph node is involved, what is the largest foci of invasion. These are all standard parameters that we report in the our reporting.
So you are seeing more T1C than you saw 5 and 10 years ago.
Yes,
Is
definitely.
that what you're trying to
Yeah,
say? Okay,
yes,
Bhavna,
definitely.
you live in a completely different, or you practice in a completely different setting. So what's the situation out
So we see very few and far between, actually, frankly
there? Right.
speaking. Our patients are mainly locally advanced, 5 centimeters, 6 centimeters. So, but we still, about 10% of patients that we see who have a screening mammogram, maybe of those, maybe 1 or 2%. Otherwise, no.
Okay.
Very rare.
Anyone wants to make a comment, please feel free. This is not a one-way, just a panel discussion. So anybody wants to add something, make a comment before we go to the next question. Okay, I think the panel is very clear that we are seeing more of these type of tumors, especially where screening is available, and a lot of private hospitals have their own screening programs. So, in such a T1C tumor, Tahir, what would you think of high risk features when you're reporting as a pathologist?
So high risk features are basically what we see in the histology. Is the most important thing is a grade. Uh,
Right,
the grade of the tumor is one of the, and second most important thing is a biomarker studies. How
right,
the ERPR status is, and if it is a ERPR positive tumor, then what is the level of Ki-67? So
correct.
these are the
Okay.
important point that we see how tumor is aggressive and what will be the further treatment of it.
Anjali, anything else you would look for in a T1C?
Basically, TNBCs and HER2 positives you would consider high risk compared to your ERPR positives.
Absolutely. So it's the grade and it's the subtype. And anybody wishes, Nita, you want to add a comment here? Or should we go to the next point?
No, I think go ahead because basically we're all looking at the subtype and grade. But here's my concern, right? The minute you've got a TNBC or HER2 positive, you know that this is potentially going to be a slightly higher risk lesion versus
Correct,
an ERPR positive where you may
correct,
have a lower grade 2
correct,
lesion. We barely see
correct,
grade 1 lesions in our system.
correct. So let's bring Dr. Kothari in because he's, I think the UK and the EBCTCG has been so big on giving us all this data. Uh, is there really a high recurrence risk in these T1C N0 bad subtype tumors? What's your take on this? Okay, he may not be there. Nita, would you like to go?
I think you're on mute, Dr. Kothari.
Sorry, that's my stupidity. Okay. So yeah. So basically, like as people said, I think I would like to take the question divided into subgroups. So ER positive, HER2 positive, and ER negative, HER2 positive. And those, treated with which are ERPR positive and HER2 positive have a better 5-year survival rate than the ER negative 5-year and HER2 positive for both for overall survival and for disease-free survival. And of course, as you said, in a T1C, if you're going to de-escalate the chemo and give them Pacli, then there's something that makes sense. And you want to see whether there is a complete pathological response.
Correct.
Then I would
So-
say, okay, let's give them. But otherwise, I think I'm a surgeon. And I think because even the NCCN and St. Gallen's guidelines are very, very selective in who.
Very selective.
And they're woolly.
And-
They put the ball back in our court to say when you
Correct.
high risk. And high
Correct.
risk base, high risk can be high risk in someone's hands and not high risk someone else's interpretation. So
Absolutely.
getting a
So,
consensus on this is going to be a little challenging, but all the best.
no, we're not going to aim for a consensus. That's why we're discussing it, because we're seeing more of these tumors in the clinic.
Mm.
So, just to give everyone a sense of recurrence rates, and we've estimated these from the EBCTCG collaborative group data, and they looked at adjuvant trastuzumab trials. That's where you got the information of these N0 tumors with which were T1C, and you could see that those that were not treated had about a 10-year recurrence risk of as high as 23%, and those who were treated with trastuzumab, it came down substantially, but even then it was 16%. So yes, there is a risk even in these smaller tumors, which is why I think our cutoff as medical oncologists for giving adjuvant chemo in these patients is any T1B tumor, and less than 5 we really don't bother much. So, what about triple negative? This is retrospective data from the US, and 83% of this pool data had T1C disease, and it showed that they had a much larger benefit with adjuvant therapy as compared to T1A and B. So, you can see the curves nicely separating. That's the overall survival probability of T1C TNBC with and without chemo. And if you broke it up into various subtypes, T1A, B, and C, you can clearly look at the 5-year survival probability down there at the bottom. Whereas it's in the high 90s without any adjuvant therapy in T1A and B, it's only 71%, 75% in patients with T1C. So, yes, that jump in size, even in node negative patients, does matter in triple negative breast cancer. So, if at all, and you do think really of neoadjuvant, what would be that particular selective case that you would even consider it, if at all? So, Pranjali, have you in your, let's do some experience sharing. Have you in the past done this?
So, for small tumors, like small TNBCs, yes, I have done neoadjuvant even for like tumors as small as 1.8, 2.2. And sometimes, people are questioning why I'm doing that. I was doing it because we TNBCs in our young, regardless of age now, we're universally doing BRCA testing, and that BRCA testing used to be taking 6-8 weeks. Now, the labs are doing it for us in 2 weeks. So we're no longer using that as a reason to. So now my only indication to do it is because you are going to change what you do based on whether you get a PAT CR or not. And you'll perhaps do that even for a 2 centimeter tumor. So that's the reason to do it.
Do you agree? Or is there any experience where
So
you kind
again,
of,
I completely agree with her that the earlier indication for us used to be waiting for BRCA and then to have that discussion again. Though we
yeah.
have operated a lot of them as upfront BCTs, kept them on follow up. A lot of patients don't want to do prophylactic surgeries in the same sitting, want to get treatment over with, want to have that discussion 2 years later. You have an informed decision making session with your patient. It's basically shared decision making. Now the difference is that, like she said, because you get reports much earlier now, that's really not on the table. That's not a point of concern. But I'm going to put one more thing out there, is that the only reason that we're doing this, and for anything that's T2 node positive, we're all pushing for NACT first. We're all on the same page there. But that's because you expect to get a benefit with response based therapy later, right? Where you add your capecitabine, TDM1, etc. My concern is how many T1C N0s don't achieve PAT CR.
Yeah. I agree, because the smaller the tumor,
The
especially a high
higher
risk
the,
like
yeah,
these, with good optimal systemic therapy,
systemic.
it's
So
much easier to get a PAT-CR than in larger node positive.
exactly. So, I mean, how much are we really changing for this patient
I think, like
is
Dr. Ashutosh said, when you're thinking of de-escalation, now if I have a 1.8 centimeter or 1.9 centimeter, a HER2 positive tumor, I can get away with paclitaxel alone, right? I would have done the APT regimen later. I would do it up front, and I wouldn't go crazy giving pertuzumab in a node negative patient with a really small tumor if it came up. Whereas on the other hand, if the patient, the other advantage is you kind of make them, if you happen to have a node positive and you've given adequate therapy and the patient does get a PAT CR, then you're stuck again because the patient was node positive, got a PAT CR just with trastuzumab, and you know that other drugs may have helped. So it's a bit of a conundrum here. And like mentioned, I
The
mean,
one thing
these
I
are all, yes,
Yeah,
go
one
ahead.
thing I had is, back in the day, I was also concerned that I might be over-treating the axilla in the neoadjuvant patients because we were routinely doing axillary dissections post chemo if we hadn't staged the axilla upfront. But now with the newer data, ability to do sentinel nodes in our N0s,
And
at
neoadjuvant,
this go along.
absolutely.
Yeah, I mean, at some point I was doing chemo ports and doing my sentinel nodes before chemo if I had a strong a
Right,
reason to do the N0 as a neoadjuvant approach, but now we're no longer
absolutely.
doing that.
Meena, what kind of node positivity do you expect in T1C tumors? Is it as high as
So,
20%?
so I don't think so. I mean, I actually went back and looked at this. So I think what happens is it's two things. You see a lot of triple negatives are going to be node negative, even larger tumors. So a
Right.
T1C, I don't really expect it to be this high.
Mm.
I'm going to say it's a lot of
This is
factors,
what's re-
including,
because this is what's
right.
reported,
But
and
I'm going to
I
say that it's a lot of factors because now most of us get ultrasounds of the axilla done.
okay,
If you have good radiology reporting, that's more or less, you can bring down that false negative. And the second thing that
right.
also happens is it depends on tumor location. So if you've got a periareolar tumor, or
Mm,
an extreme upper outer quadrant tumor, then even
mm.
small tumors you expect to
They
get
will
node
yes.
positivity.
Okay, okay,
So I'm going to say it's not just one thing in terms of size. I'm going to say that I would look at radiology done at a good center, and I would
right.
also look at location of the tumor with that.
So I would just like to share two cases which I happened to treat in the last 1 year. And I'm sure you can all guess who the surgeon is. But this is a 65-year-old lady. She's had a renal transplant for chronic renal failure. So basically got just one kidney and has a screen detected 1.1 centimeter right breast lesion. Clinically, axilla is negative. Ultrasound also proves that. And the core biopsy shows that it's triple negative. So the breast surgeon said, I'm not touching her right now. You go ahead with neoadjuvant. And it was challenging to give her therapy. I did not use anything but single agent paclitaxel at 80 per meter squared. That too, she couldn't complete 12 doses. She completed 10. And good for her. She had a PAT CR and no further treatment. So, there are patients with these kind of very weird situations where you may need to be a little more. He wanted to judge the biology, I guess, of the disease. So I went ahead and did. So any thoughts on this case?
So I'm going to
Bhavna,
ask
any thoughts?
how many before Bhavna answers this. I'm going to ask how many surgeons in the forum would send this patient across for NACT because I don't think I would have.
I would have
Not
primarily
me.
waited on this patient.
Not me also, Neeta. Hi.
Yeah.
I would have also operated first.
Yeah. So I'm just wondering, I mean, it's surprising to hear that someone who's also got comorbids,
Hmm.
being sent across for NACT with a 1.1 centimeter
Maybe the
lesion.
referring surgeon did not have time. Maybe.
So I think I would think this is a lady who has a chronic comorbidity, and you want to maximize her chances of being cured. I would strongly favor neoadjuvant chemotherapy here. And then you know the biology that she's had a PAT CR. I mean, she
So
does
you
not
can
need maybe
safely avoid
olaparib, or she does
any
not
more
need
treatment.
capside. Yeah, yeah.
I think that's the reason
Absolutely. She would
because,
need
see,
post-op chemo
correct.
anyway.
So, Neeta, just to tell you that if this sort of patient had come to me post-operatively,
Mm.
okay, I would maybe have felt a little bad because we are there's no hardcore data, but we know that these T1Cs do badly, as we saw. And I would like to, I would have wanted to optimize her chemo and do an anthrataxane, or maybe at least give something like a,
अरे आवाज बंद
TC or
करो
something,
भाई.
or maybe, even add a little platinum if I couldn't give anthra. So we got away with quite a bit of de-escalation in this case.
So can I ask a stupid question? Maybe I missed it. How did you know this patient had PAT CR?
We operated finally, no?
Oh, you did operate on her. Okay.
Ah,
No,
So
no.
you
I
said
think
no
by the
further
no
treatment.
further
he
treatment,
was
she
trying
means no
to,
further chemo.
Oh, and no radiation either.
Yeah.
Mastectomy maybe.
the
Was that a
mastectomy.
mastectomy?
Yes.
Yeah.
Why did you do a mastectomy? So you
Now,
defeated the
I'm not
purpose of
getting
giving
into
neoadjuvant
that.
chemotherapy.
I'm not getting into that, Dr. Kothari, but that's what was done. And she was very happy. She had very tiny breasts. It didn't matter to her. She was more concerned about her kidneys at that stage. So that's all the conversation was about. But I would have felt guilty if she had come to me in the adjuvant setting and I, would not have been able to give her more chemotherapy. And here it was good that we got away with just 10 doses. I'm not saying, that this is ideal, but it's something to think about. Okay, let's go to the second one. So these are the bits of experience I've had. This is a 45-year-old premenopausal lady whose tumor is borderline T1C, 1.9 centimeters to 2 centimeters. Again, a HER2 positive, clinically node negative, ultrasound negative. The question is, would she be a candidate for neoadjuvant?
No.
This kind of patient you would like just assess for whether your goal is to do a breast conservation. Is it away from the nipple? If it is I've done this in like multi-centric T1 lesions where you have that typical HER2 disease, HER2 positive
Right.
disease with high-grade DCS going towards NAC, and I'm like, okay, can I spare the NAC if I do the
Okay.
neoadjuvant and those kind of things? But that would be very case specific about anatomy of the
So,
lesion.
Shona, I'll tell you what I feel that I've started doing in the clinic, and I've discussed this with one or two colleagues also, is that my first discussion in 1.9, I mean, is really on the fence, but let's say she was 2.5. A lot of the discussion first starts with affordability for TDM1.
Okay. So
Because
you go the
if,
reverse way.
yeah,
Yeah.
so if they tell you that, TDM1's not an option, and I do see a lot of that in the practice, that they cannot do 1 year of it right now, uh, we tend to then talk to them about what's been the previous standard of care. So I end up drawing out an algorithm showing them what the two options are and why the neoadjuvant makes sense in someone who's 2.5 centimeters, but most of it banks on the use of TDM1. So if
See,
that's not an option, all I'm doing is prognosticating her.
the likelihood, see, so in a largish tumor, the APT trial doesn't apply. Okay, it was
Hmm.
very clear that only very few patients were more
Correct.
than 2 centimeters. So if you give me a 2.5 or 2.8 centimeter tumor and you tell me to use 12 weeks of paclitaxel, I'm not going to do that
Correct.
because
But
that
if
out
this
of those
patient can't do
400 represent
TDM1,
patient can't do TTM1, the patient cannot do trast and PERT,
yeah,
right? If it's on a younger side, then I would be tempted to do an ACTH and
correct.
then probably trastuzumab as a maintenance for a
Hmm.
full year. So that would be my way of treating her in the
Yeah, so,
adjuvant setting or in the neoadjuvant
correct.
setting.
So for these sort of patients, where the node negatives, but slightly larger, kind of small T2s, most of these discussions that we tend to have are, I mean,
Based
correct me if
around
I'm
the
wrong, yeah,
economics.
based around financial toxicity. I'm going to put it
But
that way.
isn't it ironical that the patients that can afford TDM1 are those that will afford the dual anti-HER2 in the
Yes,
neoadjuvant setting
yes,
will be more likely to get a PAT CR?
yeah, completely.
So now, would you push for Trastpert now that it's become more affordable in the neoadjuvant setting? If the patient can't afford TDM1, that's my
So I
question.
think we do talk to most patients.
So,
I am still not. Uh, I still most of the patients that we have on board still don't do pertuzumab.
Mhm.
You
So
know,
one point I'll add is, a lot of times once the medical oncologists have counseled about benefit of dual anti-HER2, they come back to the surgeon and ask, should I really do this? There is
yeah.
unnecessary cost. And when cost is a constraint in the neoadjuvant setting, what we have done for some patients is gotten them started on the TCH kind of, or just the single anti-HER2
Right,
agent. And then down the line,
right.
with an interval assessment, which we do with an ultrasound, and it's like, it's responding, but it's not that great. Would you consider adding pertuzumab? May not be in the small tumor situation, but for the point about the dual anti-HER2, we have done that on a couple of patients where we started
I,
off single and then added it in because we were just, and that's really objective. There's no, oh, so much of a volume response you got versus didn't 6 cycles of the weekly in or, 3 cycles.
so I'll tell you what I do. I don't switch treatment halfway or anything. I don't go by the response only. So I try and play it safe. If they can't afford it, I do for AC and then I do for THP. And that is a known regimen, all right? Because AC is still going to work well in a HER2 positive tumor. So you're getting those 12 weeks of dual anti-HER2 in without compromising the first 4 cycles, right? And most of the neoadjuvant dual anti-HER2 use 12 weeks.
But if they had a great response after those 12 weeks, would you skip your anthracycline? Or if they had complete response and if you did the initial
So
weekly,
then you'd start, then the thing that makes the most sense is to do 12 weeks of dual anti-HER2 with weekly Taxol and then take a call. And if they don't have a great response, add the ACN and then go for surgery.
But so here's my question: if you do weekly Pacley dual target weekly, and your patient for whatever
Target
reason has
weekly,
no,
weekly
and
Pacley,
you've not yet given the anthra,
yes.
okay, and your patient has complete clinical radiological response, you're not going to omit the anthra, are you?
No, I don't go. I mean, how you have to stick to you have to decide right in the beginning what you're going to do.
Correct. That's the question. So Shalaka has
Yeah,
asked a
so
couple of questions. Shalaka, do you want to ask your questions?
Yeah, no, I was just wondering ma'am, in this setting where, we come across node positive, then we do recommend giving trastuzumab and pertuzumab in the
yes,
neoadjuvant
yes.
setting, right? So for a tumor size cutoff, is it 2 centimeter, like a T2? Would you then consider dual blockade, dual anti-HER2?
So I'm being honest, in practice, anything 3 centimeters and more, I do
3 centimeters.
consider a dual bond. And
So
I'm
three
more
centimeters,
inclined,
right?
and I'm more
Hmm.
inclined to give it when the ERPR is negative also. That also pushes me in that. But so if I had a 2.8 centimeter tumor, clinically node negative with a ERPR negative, HER2 positive, I know her PAT CR rate is going to be close to 80%. So I'm pretty confident giving.
Right. So three
Whatever
centimeters is
the
not like all T2s, but 3 centimeter you consider, because
I,
even we
I
do the
I
same.
use that.
Yeah.
That's a reasonable cutoff. I use
Reasonable.
You
that.
know, Shona, in the APT trial, there were very few who were 3 centimeter. They
There
were
were
mostly
40. There
actually,
were 40 patients who were T2.
I mean, I would take 2 centimeter as because the risk of recurrence and everything goes up after 2 centimeter. So
You
I would
want to
go
take
with
two
2 rather than
centimeters
3.
your
Yeah.
cutoff. Because
Yeah.
see, we use Anthra 2 after those 12 weeks. So we are
So
not
again,
using
one can do anthra sparing regimen as well
correct.
with dosi carbo pH, especially if they have comorbidities. Younger patients, I wouldn't avoid anthra. I would definitely give anthra.
So
of
how do you do it? You do for Anthra and then for THP, or how do
Yeah,
you do it?
AC TPH, dose dense
Yeah,
AC, and then
yeah,
4 cycles of TPH. Yeah.
yeah.
So, ma'am,
I
I
think
have
that's it.
another. Actually, I saw a patient in the OPD today with that kind of a situation. a 6 centimeter lump, and our medical oncologist also decided to give 4 cycles dose dense AC, which was fine, but no response to AC. So should I
No,
go ahead and ask?
Shalaka, no, I would, you have to clinically review every cycle. And sometimes if a patient has seen different doctors, I would do an ultrasound after 3. And if the tumor has not shrunk, I would go for TPH earlier.
Right. But now, if at
Yeah.
the end of 4 cycles she's come to the surgeon and there isn't, maybe
She's
there is some
HER2
response.
positive. She's HER2
HER2 positive,
positive.
yes, triple
So
positive.
that, so if she's not progressed, I would still give her a chance with
Yes.
anti-HER2, na?
Yes, TPH. Yeah.
No, I was wondering, should we, because HER2 positive tumors are technically quite sensitive to adrimycin as well, right? So if she did
Not
not respond to,
necessarily, not necessarily, unless they are topo 2 overexpressors, they may not respond. So an ER positive, the response is lesser, but she must
Correct.
see anti-HER2 therapy before surgery. And
So,
that's definitely because it's 6 centimeter as well.
so which is why we have a question in the group, which actually I think some of us do see in the clinic, is like you said, you decide your treatment at the start. So let's say your patient's on a TCH regimen, and after 3 or 4 cycles, you're not seeing clinical response. What happens then? See, when you're doing AC TCHP, you have the option of still giving the targeted therapy. When
Yeah.
you're doing TCHP and you're not seeing a response, what then? Do you add an anthra? Do you just
Yes,
operate
you
and
do.
then
You do.
you would?
I have done that,
So you
and
mean
we've
you'll give
had a
4
fantastic
TCH,
response. Huh?
you'll move from 4 TCH, or it's TCHP. What were you saying, Nita?
TCH or TCHP.
I've
And
Yeah, you
really
would
not
give
seen a
answer
response
because
with TCHP. I've really not seen a
I've
response.
never seen a progression on
Honestly.
TCHP, but like I said, TCH not very adequate response. We've added
Uh,
pertuzumab because they weren't given
yeah,
pertuzumab.
or
you could,
given AC, because some of
yeah,
them have a
I think
fantastic response to ACNE.
absolutely.
Yeah.
Yeah,
and when you're giving TCHP AC, so I remember that, when we've had this discussion once, and this was one of the sort of tumor boards that we had done in TMH, where we always said that you want to give the targeted first. So
right.
So,
wouldn't you want to?
I mean, this is all hypothetical. I mean, Ash may
Hmm.
correct me if I'm wrong. There is some studies that, that giving anthra first followed by TCHP, it's just priming the cells. There is some rationale behind it. But,
Okay.
we have in clinic sometimes started with weekly Pacli trastuzumab so many times.
Hmm.
And quite a few of us do that. And you have to, of course, repeat an echo after 12 weeks, and if the echo is fine, then go with anthra. So you can chop and change, and I think there was a
Absolutely.
small study on
Absolutely.
that as well. Yeah.
No, and the reversal, there is a small study, it's not randomized, which shows that the taxane Pacley uh, front works better. But the MD Anderson people always give their taxane first. Whether it's
They
for HER2 positive or not, their protocol is a FECT protocol. So it's a TFEC protocol earlier on, and now TEC or TAC.
But
So
why?
they've always gone ulta. I can't understand, but all the MD Anderson protocols I've read
There
is
was
the
a
taxane
study from
upfront.
Anderson which had, like I think, Isabel Bedouin. These guys had done a study which had shown that but there was no pertuzumab at that time, but giving the anti-HER2 set with
Correct.
the
And
vaccines, they
the
do. They
NOAA
do
study,
but
this
of course,
all
it
were like
only
that.
looked at PAT-CR and not any
Correct.
survival or anything else. But PAT-CR rates were better in the group that got the taxane with anti-HER2.
so
So Nita, do you still not believe in PATCR?
No, I don't not believe in PAT-CR, but my point with PAT-CR is there has to be a reason for it. So just telling the patient you achieved PAT-CR, okay, you look like you have better disease, that's not enough for me to offer it to them. So I believe in the concept of response or risk adapted therapy, which is that if you don't achieve PAT-CR, I
Absolutely.
want to give you something beyond that. So that
Absolutely.
something beyond that has to be feasible for them, has to be a viable option for them. Beyond that, I'm not yet sold out on wanting PATCR for just achieving it.
So Dr. Tahir, tell me, how do you report PATCR in your laboratory? Do you use the older Miller Pain methods, or have you just stuck to RCP now?
So we used to have a Miller method or Mandard method. There are different methods were there, like TRNR method was also there. But now, as we mature, we just use the RCB score currently, and we are using the definition which is provided by the US FDA for the PET-CR, which is there should be no residual invasive tumor. The word is important. Invasive DCI is still allowed. Uh, Residual invasive tumor in the tumor bed and no tumor in the submitted lymph nodes. This is the exact definition of the US FDA PET-CR. So there are actually two definitions of PET-CR. One is component of DCI can be present in the uh, tumor bed. And
Primary tumor.
yeah, and there should be no metastasis. The second point, the US FDA is it should be on the morphological criteria. It should not be on based on the IHC criteria. So
Okay.
So if we use IHC, the PHCR rate become down. But to achieve the universality in the whole world, they omitted the IHC. So only on the morphological examination, it should be reported the PHCR.
Okay. All right. So I think most of us have now switched to RCB, and the beauty of this system is that you have excellent correlation with outcomes, and they've shown that a number of times. And this is a very old paper by Cortazar, and a lot of us got influenced by this. A lot of older trials were included in this meta-analysis, and it clearly showed that at the individual level, there was definitely a good prognostic piece of information you got. The individual patient who got PAT-CR did very well, but from the trial point of view, it really did not correlate, and the R-squared coefficient was really low, and the magnitude of PAT-CR did not correlate well with the magnitude of event-free survival. And there was really very little trial association. So a lot of us really were very disillusioned with this desire to get a PAT-CR. But there were other pooled analyses, again showing a strong correlation with EFS, but magnitude again very varied. And these trials were powered mainly for differences in PAT-CR, not really for long-term outcomes. But we have a more recent piece of evidence which was published in 2020, and this is in the AACR, or the Clinical Cancer Research Journal. And this is a very nice meta analysis. If you haven't read it, I would really recommend it. And what they clearly show here is, and they've looked at across 52 trials, and they stopped at 2016, so they haven't included the triple negative pembro trial. And they showed a hazard ratio of 0.31 for recurrence or for event-free survival, and they showed a hazard ratio of 0.22 for overall survival across all these studies. And it is an interesting, nice piece of data. And for the first time, the authors also looked at the effect of adjuvant therapy on EFS and OS, and whether the patients received adjuvant therapy or not in triple negative or HER2 positive, PAT-CR still remained well associated with improved EFS and OS. So it is a great surrogate for drug development, especially. And now we come to Nita's point that it is important for us from the risk adapted point of view. So capecitabine is still a great drug, very relevant for triple negative tumors. So let me ask Bhavna. Bhavna, uh, are you still using capecitabine regularly in your practice? And what kind of doses do you use? And do your patients remain compliant with it? Because I think after a whole lot of chemotherapy, are they still inclined to complete 6 months of treatment?
So yeah, I'm using it quite frequently in those with high risk. There are some patients, there was some data with 1 year of capecitabine. So there are some patients who heavy node positive, more than 4 nodes positive. I may consider for 1 year, especially if they have tolerated the drug well. The dose is we are supposed to use 1,250 milligrams per meter square BD, but I think most of our patients don't go above
They don't
1,000.
tolerate that.
Yeah,
Correct.
so about so it's 2,000 per day, meter per milligrams per meter square. So I just wanted to
Okay.
say one thing, Shona. See, HER2 positive, we are very clear about the chemo and stuff. Because and the way you've discussed it is fantastic. But it's in T1C triple negative, we have these dilemma, whether especially in adjuvant, if and most of the times I see surgeons have operated and then the patients come, whether you give TC times 4, whether you give Pacli carbo, whether you give uh, immunotherapy, and then nowadays patients come with PDL1 also in early breast cancer. And I think we must say that PDL1 in none of the trials was done in early breast cancer. It's done in advanced breast
Absolutely.
cancer.
It was
Yeah.
stage 2 and 3 up. So these kind of tumors would not qualify. But Bhavna, ever since platinum came out, and I know Sudeep's data is again for advanced uh, uh, stage 2 and 3 tumors. Is that right, Shalaka? It did not include
Yes.
T1C tumors. But
Yes, ma'am.
after using carboplatin in these stage 1 and 2s, my PAT-CR rate is around 50% in these patients
Yeah.
just with platinum. And you don't need to, they can't afford pembrolizumab. I really don't feel very bad as long as I can give them good platinum and they're able to complete their treatment. They do really well.
Yeah. I mean, we have a patient admitted with 15 out of 15 nodes
Oh my
positive. Now the and post surgery. So, the question is which the family very validly is asking, should they give pembro, and comes with PDL1 testing? But again, there's no data for adjuvant
There's
pembro.
no data for adjuvant.
Yes, absolutely.
There was a bit of data presented, I think, last year, and that didn't show a whole lot of benefit. So adjuvant, we are still very iffy, and I think the teaching is that when the tumor is in situ with your lymph nodes intact, you would better be able to mount an immunological response. I
Yeah.
think
Yeah.
that's the teaching that we have. And I'm feeling bad because I don't think CAPE alone can rescue this lady. So uh, it's going to be hell of a uphill climb for you with 15
So,
nodes positive.
Shona, I'm going to, put something out there which came out in last year, San Antonio, actually, where there was an educational session on exactly this, right? Surgery versus NACT in the T1Cs. And in CreateX, there is only 4% representation of
Yes,
T1N0s.
yes, yes.
So it's not really an answer that we have for that group and that
So it
population
included a
completely.
very small group. But see, if you have T1C with residual disease, that itself is telling you it's a terrible prognosis that you're dealing with, right? Because you do expect these patients, and in CreateX, I don't think they gave platinum regularly. It was still a ACT protocol that these patients got in CreateX. It's a much older study, it's 10 years
Hmm.
out. The introduction of platinum has been in the last 8 to 10 years. So I don't think Create X used platinum, but having used platinum, if you get residual disease, then we know we're dealing with a very resistant tumor.
No, so I agree with what Bhavna is saying is that T1C is primarily underrepresented in all trials. And that's
Correct,
because it's not been a big number in practice
correct,
also, right?
correct.
So, which is why extrapolating all the data automatically to T1C, I'm not sure if we're there yet. That's the point
Absolutely.
I'm making.
And I think that's why we're having this discussion today, because we have very little data really to go on in this particular subgroup. And Catherine, you're all aware of the more recent benefit has been in the overall survival at 7 years. The IDFS benefit is now 13.7. And they included patients with T1C, but again, very few patients had T1C disease. And even with 2 millimeter residual disease, there is a benefit. So, you know, actually, anything RCB1 upwards, you should be recommending TDF1 and even patients who are ERPR positive or negative, as the case may be. So, this is a controversial piece of data that Nita and I have come across, and we decided to put it forward. It was published last year, and it is informative, but it goes the other way. And what they did was they looked at retrospective data from the SEER database for these T1 triple negatives. And they got almost more than 5,000 patients receiving adjuvant therapy, 845 got neoadjuvant. Then they compared the prognostic impact of, we don't know which treatments, but the type of treatment in T1 tumors. And they actually found there was no difference in the overall or breast cancer specific survival between the two, and even in a subset which was later turned out to be positive. But Nita, your thoughts on this particular study? It was published in scientific reports.
No, so I agree with what you're saying in terms of that, the systemic therapy is older, they are older studies. But here's my point. There isn't still stable data to just say that neoadjuvant is the way to go,
Right,
right?
right.
I still think that we need to find something which tells us which is a worse prognostic. And that's what I had pushed for when we were there, is trying to understand and create a signature out of a core biopsy, which tells us who's a who's poor biology and who's not, who's potentially going to be a responder or not.
Right
And
now, we just have those 5 subtypes, and that really tells you nothing.
nothing, it tells you
So
absolutely
you,
nothing about that, so
so you
i
do
think that
need a
I think the
genomic signature.
direction that we need to move in is very different when it comes to smaller tumors, which we are calling high risk. We cannot just start saying everybody needs to have chemo. We don't have the data. I mean, neoadjuvant chemo, we don't have the data to say that. Yes, this data does sound very promising for surgeons to say that, there was no difference, everything looks the same, but we haven't used what are conventional treatments that we're using today.
But see the difference in the balance of the arms. See, they did a propensity score matching, which
Mm,
means they got alike patients to match the cohort with neoadjuvant from
mm.
the adjuvant group. So stage by stage, characteristic by characteristic. But if you look at the baseline before the propensity score, you can see that N1 patients were 15% in the adjuvant, and in the neoadjuvant, they were 31%. So,
So
there
that
is an inherent bias in
that
these
is an inherent
retrospective
bias even with
studies. Yeah,
the way our practice is, right?
yeah,
So
yeah.
so I get, where we are trying to do things better and we do want things to look better, but I think the toxicity that comes with it all, we need to also account for that. So just to take you back to your first case, someone with uh, chronic renal disease, I would rather get surgery out of the way, because that's a very big chunk of getting her tumor out of the way, than having her become more increasing with comorbids and not be amenable for surgery at a later date, etc. So it's always a balance of the two. And I don't
Absolutely.
think that, surgery is not a good plan as a first option for many of these women. Node positives, slightly different discussion, because it's telling you a small tumor, node positive, very aggressive biology. It's showing you slightly more aggressive biology by being that. It may be location based, it may be biology based, but
Right.
just for the fact that it's not less than 1 centimeter, that's the reason to give NACT. I don't think I'm convinced with the data yet.
So,
Sorry,
I
Second,
would,
Shalaka wanted to ask something, and
of
then I think
course,
Bhavna
Shalaka,
had a
go
couple
ahead.
of comments.
Go
Yeah,
ahead.
so I didn't want to interrupt you, but I just have one thing for the pathological complete response bit, and then for the Catherine study. So, uh, we since I think in 2009, I must have heard this, that we need to have biomarkers to identify who's going to get PCR versus not, but we still don't have. So we did a study where we propensity score matched 400 odd patients, 200, 200 approximately on both sides, early breast cancer, triple negative, and compared those who had upfront surgery with those who had chemo first. And these were sometimes decisions made maybe just because there was no date for surgery, they got chemo. So they were random decisions. Or some of us felt that maybe she needs to get NACT, or the BT ratio was inadequate. So there isn't, of course, this is not a randomized trial, but when we looked at the Kaplan Meier curves, the patients who had surgery first did slightly better than those who had NACT first. After propensity score matching for T and N stage, And that's what the question I was asking you, Nita, that day is like, because we have only 400 patients, I would like to pool data from all over, and I will become a member if
Yeah. So
I will.
Geeta,
When
this
was
is
this study
basically
done,
she.
Shalaka? When was this study done?
So this is between 2016 and 19. So there are two caveats. We didn't have pembrolizumab in the picture at that time, and we
Right.
didn't have. So I'll also tell you something else that we did. So we split the Kaplan-Meier for PCRs versus non-PCRs versus upfront surgery. And when we put
Okay.
all when we put all these three together, anyway, let me tell you that the p-value was not significant when we did PSM
Okay.
and compared. So maybe either our numbers were short, or maybe we should say that it doesn't matter whether you operate first or give NSCT first. But then
Okay.
again, it's not a randomized trial. And the other
Yeah.
thing that we found, Nita, was interesting was that when we operated first for similar kind of tumors, there was a 30% nodal positivity in upfront surgery. And when we gave chemo first, the nodal positivity was 15%. So we
Yeah,
did
but that we
downstage
expect
50%, huh?
because
That we expect.
that's a slightly
Yeah.
mixed group of
Yeah.
Of
tumor
course. Of
sizes.
Yeah.
course.
Yeah.
So we can say
I really like Geeta's comment, but before Geeta, I want you to make that comment in person. But before Geeta makes that comment, Geeta, this is what Shalaka wants to float with the CBCS. So I've told her become a member and then she can float the project.
Yeah, absolutely. Become a member first.
Yeah.
yeah,
So
yeah. I'll do that.
Geeta,
I'll do that. It's
yeah,
been on my
Geeta, can
mind.
you make your comment? I really like it. I want to see Shona's opinion on it.
So my so this is something that I've always believed, and that is that there are I think we are over treating some triple negatives also just because we don't know who are the good ones and the bad ones. We'll end up treating all of them. And if you see all those patients whom you see at 8 years, 10 years, 15 years, these are TNBCs who are coming back to you for follow-up. And the disease has not come back to bother them. So probably we over-treated those patients. And I sincerely believe that when we have a signature or a biomarker to figure out which ones are the good ones and bad ones, I think about 30-40% of TNBCs would not require chemotherapy. We already know that, adenoid cystic carcinomas, triple negative breast cancer, we
Yes,
don't give them any
absolutely.
systemic
They don't.
treatment.
Yeah.
So there are a lot of these indolent TNBCs which we are possibly over treating
Yeah.
with systemic
Over
treatment.
treating.
Yeah.
Okay. Dr. Kothari, have you been using HER2-DX for HER2 positive tumors to predict PATCR and prognosticate patients in the UK?
Not in regular clinical practice, no.
And is there a signature for triple negative along the way? Is there any clue from the lab there?
I am not aware of anything that is being translated into clinical practice. There may be something which is still being researched, but nothing
Right.
is imminently coming that we can kind of hope that next year or 2026 we'll have that signature.
I think
TNDX.
it's such an unstable disease compared to the ER positives and the HER2 positives. There's so much genomic instability. It might be very difficult to get a signature of these patients.
Absolutely.
Yeah, so the other point was, ma'am, if you allow me, was that Catherine, the
Huh?
subset of TNBC was only 30%, isn't it? Because Catherine had even ERPR positive tumors. But we don't
Yes.
ever consider giving capecitabine in ERPR positive tumors because we still have the endocrine therapy backup.
No, 1 minute. You're talking of Catherine
That
or
is
Createx?
TDM1.
Sorry, Createx. I'm sorry,
Createx.
Createx.
Huh.
Yeah, Createx. So how do we explain that? Because it's a 30% of the overall Createx population was triple negative, right?
So yes, so this was the triple negative that was
That you see the
assessed.
benefit
So
in.
whatever reports have been coming for Createx have been in the triple negative cohort.
But it's a
They've
subset
not,
then.
yeah, it is a subset, but it is majority of the subset, and that's the best data we have right now. So
So do we have any other trials in the
yes,
pipeline for
yes.
this?
No, so there is like Bhavna mentioned. Bhavna, you mentioned that Korean trial, no? Where you give SYUCC trial, where you give the capecitabine low dose for a year.
Yeah, yeah.
And that did also have at least, I think, an EFS benefit, if
Yeah, I
not an
think there's
OS.
no doubt about use of capecitabine. It's part of most guidelines. We can continue debating about it. But I
There are
think
two, three trials, Shalaka. I will share them
yeah,
with you.
yeah.
I don't think there's a debate because there is an overall survival benefit. We know that.
Mm.
Yes,
What
absolutely.
debate?
Yeah.
It could be 10 patients. If they have an overall survival benefit, they've got it.
Yeah.
No, I think
And
her
it's
question was
9%.
on the ERPR positive bit.
Ah,
I
But
think we have
sorry,
endocrine
side
therapy,
effect is
we
for
have
triple negatives.
CDK,
Where is ER/PR positive coming
Because
from?
Createx had both.
but
No,
we
but
have
the
CDK4/6 inhibitors now
So that's the thing.
actually.
So
And
but
because
the
we
benefit
do
was
have
only seen
both.
in triple
yeah,
negatives, and the
Yeah.
survival benefit is only seen in triple negatives. So ER/PR
correct,
positive is just trying to
correct.
confuse the matter which is already solved.
Garvit, you wanted to make a comment?
And the subset
I
analysis
was saying
actually
is like
showed good response. Yeah.
taking
Sorry,
you
sorry.
back to that CA data that we were discussing.
Hmm.
It's
huh,
making the
huh.
exact point on what you read more at CR than risk prediction and changing therapy based on risk prediction. Because if prognostication, nothing more than that. Even if those patients got a PAT CR and overall survival did not change, then we're going back to the square one, right?
Yeah, so I think the most important point of giving neoadjuvant today is the risk adapted
Correct.
therapy. I think that's been a game changer, real game changer for us. And if you can rescue a few of them, it really makes a very big difference. So that's something I look forward to. So I think we talked a lot, and it's been great having surgeons and their viewpoint. And so this is the HER2 algorithm, where it's very clear that when a patient is T1C, especially T1N0, then you can do a good surgery, give 12 weeks of the APT regimen, continue TRAST for a year. However, if the surgery reveals that the patient has a larger T2 tumor, you may want to go for 6 to 8 cycles of chemotrast. As long as the patient is node negative, you don't benefit from pertuzumab in the adjuvant setting. However, if you have a large nodal burden, and I do reserve PERT for patients who have 4 or more nodes positive, I definitely start talking to them about adjuvant pertuzumab. And of course, in patients with T2 or more or node positive, we do prefer dual anti-HER2 for 6 to 8 cycles followed by surgery. And then, of course, it's risk adapted. In early TNBC, BRCA has to be done right up front. We often don't get to do it because it takes time to convince the patient. And in T1A or T1B surgery upfront, T1C is the gray area where we've been talking about it, but I think the consensus is as long as the tumor is less than 2 centimeters, node negative clinically or on evaluation, we can go with upfront surgery. So I think that's the learning from this session today. And thank you very much. And if you want to continue the discussion, we can do it a later date. Nita, are there any
Yeah,
announcements
so
from
just our next meeting, we're going to skip May. Geeta's volunteered to take forth the next one, which will be in June. Tentative date currently is the 24th of June. We'll come back to you with exact dates on the flyer. The topic is going to basically cover mutations and germline mutations other than BRCA and
Oh,
what to do
wow.
in the clinic for that. So Geeta and Aparna are going to help us with that.
Oh, lovely. Okay. So look forward to seeing you and thank you all.
Thank
Thank
you.
you. Good night.
Thank you,
Thank
everyone.
you.
Good night. Bye.
Thank
Thank
you.
you.
Thank you.